Hello, my name is Dr. Amanda Hall and I'm a counselling psychologist and team leader for Step 2 North Bucks at Healthy Minds. My role in the service, along with my colleague Adam Lacey, team leader for the Step 2 in the south of the county, is to oversee the clinical delivery and supervision of all the psychological wellbeing practitioners, or PWPs for short. We have approximately 28 PWPs in the service, many of whom are trainees currently undertaking the Reading University PG Diploma course. At Step 2, the majority of PWPs offer the following interventions: brief screening assessments, telephone and individual face-to-face guided self-help, computerised CCBT in the form of Silver Cloud programs, and psychoeducational groups. The vast majority of PWPs work from our main base in High Wycombe, Prospect House. They also work out of GP surgeries and community venues across the county. We offer interventions based on NICE guided CBT protocols for all the anxiety disorders and depression, and the PWP's training is specifically within these intervention approaches. It is usual practice for clients to be offered between 4 to 6 sessions at Step 2 and then reviewed. Some clients will require additional support after receiving a Step 2 intervention. These clients will have been discussed with a supervisor and next steps agreed, usually stepping the client up for a Step 3 intervention or out of the service for specialist support. All PWPs have regular supervision. They have access to daily risk management drop-in supervision, which is available to all PWPs who have assessed a client that presents with risk and requires guidance on next steps. They also have weekly case management supervision, in which all cases are systematically reviewed, and monthly skills training forums. Many of the PWPs have both ongoing clinical work and project work. There are a range of projects that PWPs are involved in, including long-term physical health conditions, which offer a range of interventions for people with physical health conditions, Black and ethnic minority accessibility, the postnatal depression group, and CBTI, which is a specialist programme for insomnia, amongst other offerings. There is a dedicated PWP supervisor team comprised of CBT therapists and psychologists. So if there are any specific questions about PWP work that cannot be addressed by your current supervisor, then please feel free to approach Adam or myself.
Hello, my name is Dr. Nick King and I'm a clinical psychologist and team leader for Step 3 South Bucks at Healthy Minds. My role in the service, along with my colleague Dr. Kate Smart, team leader for Step 3 in the north of the county, is to oversee the clinical delivery and supervision of all the high intensity, also called CBT therapists in the service. We have approximately 30 high intensity therapists in the service. They come from a range of professional backgrounds, including social workers, nurses, OTs and psychologists. Most of the therapists have completed a postgrad diploma in CBT or have doctoral level qualifications in counselling or clinical psychology. We also have trainee CBT therapists in the service who are undertaking the Reading University postgrad diploma course. At Step 3, the majority of the therapists offer individual face-to-face CBT for the more complex clients that are referred here. They work out of GP surgeries and community venues across the county. We offer interventions based on NICE guided CBT protocols for all the anxiety disorders and depression, and the therapist's training is specifically within these intervention approaches. We also have clinicians trained in interpersonal therapy, IPT, behavioural couples therapy and EMDR, eye movement desensitization and reprocessing. Both IPT and CBT are evidence for depression, and both EMDR and CBT are evidence for PTSD. It's usual practice for clients to be offered 4 to 6 face-to-face sessions initially and then reviewed, but we can offer up to a maximum of 20 sessions at Step 3. We recommend not informing clients of the maximum number of sessions at Step 3, as this can set up unhelpful expectations, so it's best to explain that their clinician will discuss this with them. The appointments last for up to an hour, and we offer treatment appointments from 9 to 5, Monday to Friday. It's imperative that when you offer clients face-to-face sessions at step 3, you discuss with them their availability and explain that the more flexible they can be about the location and the day, the more quickly they will be seen. Make them aware that it's our policy to offer them 2 different appointment slots at step 3, and if they do not accept either of these, they will be discharged back to the care of their GP. Ensure that the client realises that the allocated slot is a regular one and that they will need to be able to attend weekly. It is very unusual to offer any step 3 CBT over the telephone. In addition to individual work at step 3, we sometimes offer groups, including mindfulness for depression, mindfulness for long-term conditions, and an IPT group with clients from either step 3 or step 4 psychological services. All CBT therapists have regular supervision. They're offered group, individual, clinical decision-making supervision sessions and a monthly clinical skills forum. Many of the CBT therapists have both ongoing clinical work and project work. For those who purely undertake clinical work, they're seeing 6 clients a day over 4 days a week, with 1 day at their office base for admin and supervision. There are a range of projects that CBT therapists are involved in, including older adults for carers of dementia group, long-term physical health conditions, which offer a range of interventions for people with physical health conditions and anxiety and depression, Black and minority ethnic accessibility, psychological perspectives in primary care, which is training primary care health workers in brief CBT interventions, amongst others. All of the senior supervisor team offer supervision to CBT therapists. If there are any specific questions about CBT therapist work or referrals to step 3 that cannot be addressed by your current supervisor, then please feel free to approach Kate or myself.
Hello, my name is Chai Padil and I'm the team leader for the Bucks Psychological Therapies Pathway Single Point of Access, also known as the Bucks PTP SPA or just SPA for short. First, on behalf of the SPA team, I would like to welcome you to Healthy Minds. The SPA team was set up about 2.5 years ago and consists of myself, 3 other referral coordinators or RCs who are clinical staff and 1 full-time admin staff. 3 of us referral coordinators have had experience working in adult mental health teams in secondary care. SPA deals with most of the referrals that come into the Bucks PTP, step 2 and 3 for Healthy Minds, and step 4 in psychological services in secondary care. We use Care Notes, the electronic health record used by secondary care in the Trust, and also PC Mist used at Healthy Minds. We've also got access to the patient browser to look at the notes on the previous systems used by the Trust, and we screen patients who've had previous contact or are currently being seen by the mental health services in the Bucks area only. We cover some surgeries on the border of Berkshire but do not have access to patients' notes if they've not had contact with adult mental health teams outside Bucks or Oxford as well. We do have access to Oxford. I will now talk about Healthy Minds referrals. Healthy Minds cover all the surgeries in Bucks except Milton Keynes, and we get an average of 700 referrals a month, mostly self-referrals over the phone, email, text or self-referral forms. 80% are self-referrals and the rest are referred by mostly GPs, Oxford health teams like adult mental health teams or CAMS, the child and adolescent mental health teams. And we also get referrals from midwives, district nurses, health visitors, police, probation, addiction services, Relate and numerous other agencies. The SPA team screens referrals to decide if they will be accepted at Healthy Minds for a brief screening assessment. The only referrals SPA doesn't screen are the ones where patients call the admin to self-refer over the phone, and admin during the call check on the systems and find out that they do not have previous or current history in secondary care in Bucks or Oxford. We also make decisions like whether a BSA need a qualified clinician and telephone only, for example, if they have a history of anger. We accept, decline, step up and signpost patients elsewhere if necessary. We monitor risk, do a lot of liaison work with patients, GPs, other referrals and adult mental health teams. We write our notes under triage on PCMIS, and we would encourage you to read the notes before you take on a BSA or brief screening assessment, as we will also include information about previous or current treatment and risk history, if any. Next, I'm going to talk about referrals to Step 4 Psychological Services. Step 4 Psychological Services is currently under review, meaning they will be integrating with adult mental health team in the next few months. SPA does not deal with referrals to adult mental health teams, complex needs service, eating disorder and early intervention service. The Step 4 Psychological Services criteria is on the G drive under SPA, and also usually you will also be discussing with your clinical supervisors if you want to step up patients. All referrals to Step 4 Psychological Services come to the box Psychological Therapies Referrals inbox by email, and there's also Step 4 referral letter on PCMIS with subheadings to help you. The SPA referral coordinators screen the Step 4 referrals 3 times a week over the telephone for each locality, that's Aylesbury Vale and Chiltern. And we do this with dedicated Step 4 psychologists whom we call duty workers. They tend to be the more experienced Step 4 psychologists, and with the forthcoming integration, adult mental health team will also be involved in the screening process in the near future. Step 4 Psychological Services will not accept patients who have a cluster below 4, and if you're not at this stage familiar with cluster, you will be trained before you start doing assessments. But however, bear in mind that SPA will need a cluster from you when you're stepping up to Step 4 Psychological Services. The SPA team cannot give you the outcome of your referral before the screening calls with the duty workers at Step 4 Psychological Services. Please keep your patients opened on PCMIS when you refer to Step 4 until SPA emails you back with the outcome, and it is then your responsibility to update your notes and inform patients and GPs alike. To finish, all this information with a list of the names of the clinicians and the admin staff who work in SPA, and as mentioned before, a copy of the Step 4 Psychological Services criteria can also be found in the SPA folder on the Healthy Minds G drive. The SPA team's hub is situated next to the admin area at Prospect House. Please feel free to come and say hello to myself and the SPA team, and we'll be happy to help you with any other queries you have about SPA and referrals process to Step 4. Thank you very much for your attention.
Okay, this is a podcast on clustering. It just covers a little bit about what clustering is, the background to it, and then we're going to move on to PCMIS and show how to cluster. So care clustering is a process introduced by the Department of Health. It's a means of grouping a client's needs so that we can design care packages to best meet those needs. Every patient seen in the service is allocated a care cluster number at assessment and at times of significant change. Altogether, there are 21 possible clusters ranging from 1 to 21. At Healthy Minds, we tend not to see people above cluster 8. Care clustering is becoming a mandatory requirement for all IAPT and Step 4 services across the country. It will link to payment by results, which is the way we'll be funded in the future. So a fixed price or tariff will be paid to mental health trusts for the care that they provide for each patient. We are not linked into payment by results as yet because the system hasn't been finalised, but it will be coming up. So just a visual representation of clustering. So Healthy Minds is over here in the section A, non-psychotic, so ranging from mild to very severe and complex. So there's cluster 8 there. Cluster 9 is no longer in use, and 10 and higher we won't be using. So you have psychosis here and then organic symptoms here, so we won't be working with them. Just another visual representation here. Again, Healthy Minds will be in the blue area between clusters 1 to 8. So how will we know if we're getting clustering right? We will be undergoing consistency checks to make sure that service users are being clustered as accurately as possible, even though it is a subjective process, and also to see if we need any extra training and support given to staff. Okay, so how to cluster someone. You cluster someone using the clustering tool on PCMIS, the Patient Information System. And the clustering tool is on the same page as the MDS and the disorder-specific questionnaires. So step 2 clinicians do automatic clustering, and step 3 clinicians do a full clustering assessment. So automatic clustering first. This is for all step 2 clinicians and for step 3 clinicians who are doing telephone assessments. So we're just going to go to PCMIS now and show how to do that. So come down to clustering tool, which is just here. Click on clustering tool, put in the date, and then scroll down to the bottom of the screen and click enter cluster number only. Now here you're going to enter the cluster number for the client. So if they're going to step 2, they'll be cluster 2. If they're going to step 3, cluster 3. And if they're going to step 4, cluster 4. So we're going to say in this instance that the person is going to have a step 2 treatment, so they're cluster 2. And then do save changes. So automatic clustering. It's for all step 2 clinicians and for step 3 clinicians who are doing telephone assessments. With automatic clustering, you match the cluster to the step. So following a telephone assessment, if the client is going to have step 2, then they're cluster 2. If they're going to have step 3, they're cluster 3. And if they're going to have step 4, they're cluster 4. Okay, so we're just going to go to PCMIS now to show how to do an automatic clustering. So go onto the assessments page and then come down to clustering tool. Then click on today's date and then come down to the bottom of the screen and click enter cluster number only and then enter the cluster. So if your client is going to have step 2 treatment, you would choose cluster 2 and then save changes. Okay, and so that's it for clustering at step 2 or at telephone assessment. So the next bit of clustering is for step 3 clinicians. So step 3 clinicians are going to do a full clustering assessment. So when a step 3 clinician starts seeing a client for sessions, they'll do a full clustering assessment on PCMIS, and this must be completed within the first 2 sessions of seeing somebody. So what's involved in doing the full clustering assessment is there's 2 bits. There's part 1, which is 13 questions which relate to current problems that have happened within the 2-week period prior to rating. Then there's part 2, in which there's 5 questions that consider problems from a historical perspective. So these may be problems that occur in unpredictable or episodic ways. They may not have been experienced by the person in the 2 weeks prior to the rating, but you would still include them if you think that they could be relevant to the cluster allocation. So in total there are 18 items, 13 are current and 5 are historical. Each is rated on a 5-point severity scale from 0 to 4. So 0 being no problem and 4 being severe to very severe. So a rating of either 0 or 1 could be described as everyday life, while a rating of 2 on the severity scale would indicate that a degree of care planning is necessary. So what to do if you don't have enough information? Please don't use 0 because 0 indicates that there is no problem. So if you use 0 on the clustering tool, it indicates that you have assessed for that item and found it to be not present. So if you don't have enough information, just address the item with your client at the next session when you get a chance to, because without a full set of scores, a cluster cannot be allocated. Okay, so now we're going to go to PCMIS to show how to do a full clustering assessment. So on PCMIS, click on clustering tool, click on today's date, and then go through each item one by one and give it a rating. So to help you to do that, there is a clustering booklet, which looks like this. It's on the G drive under the folder clustering. If you come down to page 8 on the booklet, it's got a very helpful grid here that will help you to choose the number that's appropriate for the person. So under each number, there's a description of what that presentation might look like for that particular number. So then on PCMIS, come back, give each item a rating. I'm just going to put in random numbers here because it won't let me do the clustering without them. So on question 8, it asks you for any other mental or behavioural problems. So that's anything that hasn't been covered by the preceding questions. So if you have something that you're rating there, it then asks you to specify what it is. So for example, obsessive compulsive disorder, then come down, keep rating. Okay, and when you get to the end, select a superclass, which for us at Healthy Minds will always be A, non-psychotic. Okay, so then click on Calculate Cluster, and then what comes up is PCMIS offers you a likelihood that that person matches a specific cluster. So it might offer you one cluster. It might say, you know, with a very high percentage of certainty that somebody is cluster 3, for example, or it might give you a choice. So it might say, you know, cluster 2, 50% likelihood, and cluster 3, 50% likelihood, for example. Ultimately, it's always going to be your decision, your judgment. So the calculate cluster function on PCMIS just gives you a suggestion. It's always going to come back to your choice. You don't have to go with the suggestions given to you by PCMIS. Okay, so just a few general guidelines when you're using the clustering tool to do a full clustering assessment is to firstly score the items in the correct order. So part 1 first, followed by part 2. And then in part 1, do not score on information you already rated in an earlier question. That's the kind of thing that makes sense when you're actually using the clustering tool. Where a question covers a number of potential problems, rate the most severe problem that occurred during the period in question. And just a final note, really, not something you have to take into consideration, but just for interest, that the score for question 1 does not contribute to the overall cluster, but it is necessary in order to measure outcomes, so therefore should be rated. Okay, so when to cluster somebody, clients will need to be assessed and clustered at the point of referral into the service, so at the telephone assessment, and at review points. And the review point depends on the specific cluster, but at least once every 6 months. So if we just return back to the clustering booklet, you will see that there is a section for each cluster number where it gives interesting information about that particular cluster. So if we go to cluster 2, for example. So cluster 2, it gives a description of what is involved in cluster 2. What would be an adequate description of somebody meeting the criteria for cluster 2. Then if you go down the page, it will tell you if somebody is that cluster, how often they should be reclustered. So on the top right hand corner you can see cluster reviews at least every 15 weeks. So for cluster 2 you recluster sometime within 15 weeks, whereas for cluster 3 it's every 6 months. You can see in the top there again, cluster reviews at least every 6 months. Okay. So, as we said, clustered at the point of referral, at review points, then at any time of crisis or any point where there is a significant change in need. And finally, if you're transferring the client from one team to another, or discharge from the service. That has been modified, that at the moment we're not needing to recluster clients on discharge from the service. That probably will change in the future when payment by results comes in, but for now we don't need to recluster at discharge. Okay, so there is also a flowchart on the G Drive that talks people through this. And finally, if you have any questions about clustering at all, and then please do get in contact with either Alice or Roz, who work in the SPA team and tend to be physically in Prospect House most days, or else Miriam O'Driscoll, High Therapist. So you can email any one of us with any clustering questions that you have, and we may not have the answer just yet because it is a developing project, but if we don't, we will find out for you and get back to you. Thanks very much.
Hi, my name's Jenny Herbert and I'm an interpersonal psychotherapist. So I'm aware that you've probably listened to a lot of these on your induction, so I'm going to try and keep it brief and just talk to you about interpersonal psychotherapy, and we like to call it IPT. So it's a therapy, it's a step 3 intervention within the service, and it's a therapy designed for people that are suffering from depression, and normally linked with relationship difficulties that are going on. So it's normally that the relationship difficulties have caused the depression, or the depression is affecting their relationships. So when you've done a BSA, you'll often find that people are kind of describing, I suppose, one of 4 things. So they'll be describing that they're severely depressed, so it needs to be on the PHQ 9 above 16. And they'll probably be talking about maybe a massive life change that's happened. So either that they've, I don't know, relocated somewhere, that they've split up with a partner, and that they're feeling that their relationships have changed because of that. Another one could be that they're in conflict with somebody. So it might be that they're in conflict with a partner or a boss or anybody, and it's kind of those constant arguments are causing them to feel depressed. A third one is a significant bereavement, so feeling that really stuck in bereavement. So this is like a bereavement that's probably going to be over a year ago, maybe 2 years ago. That there's something significant about that relationship with the deceased. It might be that there was a complicated relationship, or maybe it was a complicated death, like a suicide, and they're really feeling stuck in grief. And then obviously you can refer them to IPT. And the last one is more of a long-standing difficulty. So these are your people that will come in and say that they've suffered from a recurrent depression, that they don't really understand it, that they keep getting into the same patterns of relationships with people, that that they think, oh, why is this always happening to me? So, you know, that they're not getting their needs met, that maybe there's recurrent abuse there, and that's like really kind of adding into their depression. So I guess they're the kind of types of people that, or the types of problems that you're going to be listening out for in the BSA. So obviously they need to be depressed, and there need to be obviously some relationship difficulties going on to refer them on to IPT. So within the service, IPT is delivered either in individual or in group therapy. Both kind of process of referring is the same. So if you're feeling like you want to refer someone to us, you can always send us an email. My name's Jenny Herbert, and the other IPT therapist is Sharon Ebbets, and we kind of hold a triage system. So just send us both an email and we'll get back to you. So the criteria is they need to be obviously severely depressed, so above 16. Usually they need to have had a step 2 intervention first. So I suppose there might be the odd case that hasn't had a step 2 intervention, but you would need to consult with us first. We'd need to get it agreed with kind of your supervisor and stuff like that. So coming back to how it's delivered, so either individual or in group, we can kind of really make that decision whether we think it. I suppose the groups that we run are really different from the groups that you'd be used to in step 2. So rather than a psycho-ed group, that is kind of mainly what we offer in step 2, this group's more of a therapeutic group. So it's quite long-standing, so it's a massive commitment for an individual to sign up for. So it's for 20 weeks plus about 4 or 5 individual sessions. And these are for the people that I talked about have those long-standing difficulties. At the moment, it might have changed by the time you're reading this or listening to this podcast, but at the moment we do run some step 3, step 4 groups. So these could be people that maybe have more kind of long-standing enduring difficulties that could be accessed in step 4 interventions, but we kind of hold them within our groups really. So these are people that have got long-standing difficulties that really struggle with maintaining any relationships or starting relationships. So we kind of find that the IPT really works well within a group, because actually the whole process of therapy is actually being with individuals in that group. So there'll be 8 people in a group, and it goes on, like I said, for 20 weeks. And we kind of go through different stages. I'm not going to bore you with I suppose, the ins and outs of the group. But it is really good. Really, really works well for those people who can't really kind of tolerate any sort of relationships, or who are really sort of chaotic, and who find that basically these problems, interpersonal problems, are with all of their relationships. Then it's like best suited really within the group. Individual, like I've said, you'll kind of have one of those kind of 4 things will have happened for that person to access individual, but it's just the same process as well. So I guess that's IPT, or interpersonal psychotherapy, in a nutshell. Obviously, if anyone has any queries, because I know you've had to take on a lot within all of these inductions, there's lots of different kind of therapies within the service. Any queries, always just email me or Sharon. So I'm Jenny Herbert, then there's Sharon Eberts. We have on the G drive, there's a IPT information folder. Actually, you will find this. So that is information leaflet on IPT. Feel free to send it to clients as well. It probably describes it a little bit better to how I've described it now. It will describe it in detail, what to expect from IPT, the different sort of focal areas that I've just talked about, and what to expect from the therapist. Feel free to send it out to any service users, or just, it's sometimes quite helpful to read a little bit of clippets from it when you're trying to describe IPT at the end of those BSAs, or even after your step 2 intervention that might not have been as effective, and that you might be talking about other options really. And I've just realised I've forgotten to mention that the IPT duration, the individual, is for up to 16 sessions, just like step 3 CBT. Okay, so I think that's it. Thank you.
Welcome to the Healthy Minds Safeguarding podcast. My name is Ros, and I'm one of the safeguarding clinical leads for Healthy Minds. This podcast will explain the Healthy Minds process for reporting safeguarding concerns. This will be in addition to the Trust's mandatory training, which will enable you to identify safeguarding concerns and think about appropriate actions. When carrying out brief screening assessments, we need to ensure that we gather information about dependent children and vulnerable adults. This information should be recorded on the details page on PCMIS. Please ensure that you obtain information including the child or adult's full name, date of birth, GP and school or college attended. Please also include any other professionals involved, such as health visitors and social workers, and also their contact details. If during the brief screening assessment you identify a safeguarding concern, we would expect you to, in the first instance, discuss this with your supervisor. If your concern needs urgent attention, then you should contact one of the managers or supervisors. This would then enable you to formulate a safeguarding management plan, which may, for instance, involve a consultation with the Trust safeguarding nurses or Trust safeguarding adults team. After formulating your plan with your supervisor and taking the actions agreed, please email the safeguarding leads for the PCMIS number so that we can ensure that all documentation is up to date and there are no further actions that need to be taken. We will then log the client's details on our safeguarding log. Alice Devereux and Ros Breer are safeguarding leads for Healthy Minds. Please do email both of us with any safeguarding concerns that are ready to be reviewed. The Trust safeguarding information is available on the intranet. Please click on the green Patient Safety button and select either Safeguarding Children or Safeguarding Adults. If you're unsure, please ask your supervisor for advice.